Open the patient's mouth with your right hand and hold the laryngoscope in your left. Not too tight, with 3 or 4 fingers as close to the blade as possible for precision and control. Insert the blade in the right side of the mouth, carefully pushing the tongue aside. The aim is to create an unobstructed line of sight to the larynx by pushing the tongue to the left and lifting the epiglottis, exposing the vocal cords. This requires precision, not brute force. A common mistake at this point is leaning forward, as it feels this will give a better view. It doesn't. Stand upright with the left arm at a 90-degree angle tucked in towards your body. This allows for better ergonomics, better communication with the team, and a better overview of the ventilator, the timer, and the patient. Let's see the laryngoscopy once again. Advance the blade until you see the epiglottis and place the tip in the vallecula, the recess at the base of the tongue. At this point, you can start to apply some force in the direction of the laryngoscope shaft. Sometimes a light external force on the larynx can make the vocal cords spring into view. Ask for your assistant's hand and move it to apply backwards, upwards, rightward pressure, or burp for short. Make sure you don't pinch the lips and do not exert any pressure on the front incisors. By now you hopefully have a clear view of the opening of the trachea, a dark slit between the pale vocal cords. Insert the tube carefully. Sometimes a gentle rotation is required to pass the vocal cords. Advance the tip until the cuff has disappeared and the vocal cords are between the 2 black lines. Ask for inflation of the cuff and carefully retract the laryngoscope. Hold the tube firmly while you confirm that it's lodged in the trachea and not the esophagus. The gold standard is return of end-tidal carbon dioxide over several respiratory cycles. Be very cautious when interpreting the other signs traditionally used. Auscultation finds on both lungs, condensation in the tube, and the symmetric rise of the chest wall, as these may very well be positive despite an esophageal intubation. When you're absolutely certain that the tube is in the trachea, secure it with tape and initiate mechanical ventilation. Congratulations, you have now performed an endotracheal intubation.